We are planning for full mouth for this patient. First we will plan for the upper, this 8 unit, no? 8 unit or 6 unit. 8 unit bridge is failing because of recurrent decay, peripapillation. Recurrent decay, the bridge is moving now. If there is decay. Okay. So there are similar to mandible, there are two segments. Okay, anterior segment and posterior segment. Anterior segment from premolar to premolar and posterior segment from molar and pterygoids. Okay. So depending upon how much bone quality, quantity, it becomes a difficult or simple or medium case. The problem with posterior maxilla is sinus pneumatization, right? How much sinus has come down and in front. Okay. If you see on this side, the sinus has come down the 6th area, right? Very much time, only 2 or 3 mm bone is there. Here somewhat good bone is there, no? This may be the canine, first premolar, second premolar. This is the second molar which is migrated in front. So mostly this will be the first molar area. So what is the anterior extension? Till what extent it has anteriorly expanded. Okay. If you see here, this is the second premolar. Above the second premolar, there is some amount of good bone is there. Okay, but if you see this second premolar, the sinus have expanded till the first premolar. And of course, in this panoramic view, you cannot appreciate the anterior segment. So we will plan. The key area is to starting with the second and first premolar. Okay. So first we will plan the right side 1-5. Right. Before that we will see the panoramic, 3D refracted image. If you see here, there is very thin bone in the canine area, right? And even in premolars, very thin buccal bone. Here very thin buccal bone. So what it tells is this: during extraction you should be very careful, gentle. Otherwise this plate may fracture and it will complicate the implantation procedure. Okay. So the extraction part we should be very careful. Better to remove 2 mm of bone buccally with burr. Then we can do the extraction. Otherwise we may lose the entire buccal bone. Okay. Now one implant in the second premolar. Okay. Exactly axial placement along the socket. If you see here, the sinus is expanded very near to the apex, as we have seen from the panoramic view. About 12 mm implant. Okay. We will try tilting the implant mesially. The moment you try to tilt just 5 degree, you are getting a good bone. But still there is sinus here, no? Can you see the sinus here? So we will tilt some more in front. There is good bone now. Okay. Even if we have done 2 to 3 mm of alveoplasty, this poor thin bone we will remove. Okay. Till the nasal floor. Almost you can get 17 mm, 18 mm in place. Okay. Even you can place little closer to the buccal wall or along the palatal vault. Okay, whatever it is. Okay, so you just 10 degree tilt. It puts you into the good bone. Now what we will do is we will just extend this into the nasal floor. The reason is to check in the 3D reformated view. We will get an idea where it is exiting. Can you see? Okay, along the nasal floor. So this is the key implant, the second premolar implant. This key area we can place a good implant now. Okay. Now we will place another implant in the second premolar area.
First premolar.
Sorry, first premolar. Okay. The anatomy looks somewhat different here. Very slopey here, right? If you tilt. Let me see. We will extend into the nasal floor now. Okay. Okay. And one more implant in the 1-1 area. If you see here, the software shows they are very close here. Okay. See the why this is you have to understand this one important thing. When you see in the panoramic view, we think now 1, 2, 3, 4, 5, 6, 7, 8, 9 teeth or 10 teeth from premolar to premolar. 10 teeth. We can place 10 implants. No, not possible. Even placing 8 implants is quite difficult. Why? Because the arch form in the tooth area is like this. The arch form in the mid-root level is like this. The arch form near the apex of the tooth is like this. The arch form in the nasal floor is like this. So the arch form is very wider in the occlusal level. But as it goes upwards, the arch form becomes constricted. This we should understand. So by seeing OPG, we can plan 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 implants. But when these implants reach this segment, the nasal floor segment, they will be very much close to each other or hitting each other. So this we should keep in mind. Okay. So the number of implants which is possible, safe inter-implant distance, especially in the nasal floor, they should not be touching each other. They should not be hitting each other. This we should plan. If you place, the general rule is if you place all implants straight, you can increase the number of implants. But if you place tilted implant, that means if you are placing tilted implants in 5 region, that means you are encroaching this space. You cannot place in the 4 region you can place a straight implant, right? So this 4 area is knocked out unless you place it again a tilted implant. If you put a tilted implant in 4, you cannot place a straight implant is 3 or 2. Only in 1 area you can place a straight implant, that too a short implant you cannot reach till the nasal floor. So definitely, so only 3 implant you can place from 5 to 1, 1, 1, 1 to 1, 5. So 1, 1 to 1, 5 there are 5 teeth, but you cannot place 5 implants if you place tilted implant. So whenever you place tilted implant, the number of implants will become less. So there are one situation where you should not place tilted implants. Okay. One is very osteoporotic bone. Okay, because you need to bend. If you put a tilted implant, you need to bend. So in soft osteoporotic bones, you cannot bend. The bone will deform. The bone may break. The bone may move. And very short length available. The bone quality is good, but only short length available in the premolar area. See 12 mm or 13 mm, 4 mm. It is not wise to bend it. Better to place a straight implant. Here, so you have to decide first in a case whether you want to place a straight implant or a tilted implant. So why you place a tilted implant? Okay. Here, if you place a straight implant, you may enter the sinus. The length is not very much good. That is why you are tilting. And the bone is also good quality. You can easily bend. The two, 4.2 into 20 or 18 mm you can place. That one implant is excellent. The only thing is you don't tilt it too much. The more you tilt it too much anteriorly, you cannot difficulty in placing the anterior implants. Okay. So tilt only very minimally. So what we'll do is we'll reduce the tilting. But if you reduce the tilting, you have to go more palatally. Okay. Because if you come buccally, the sinus is coming buccally, labially. Right? If you go like this, then you will be entering the sinus. Okay. Right? So stay close to the palatal aspect. If I am tilting more mesially, see, I can come little bit buccal also. I have the freedom. I can go palatal, I can go buccal. Especially if you come buccal, you will get good bone from this. It is almost near the nasomaxillary buttress. Okay. The nasomaxillary buttress, the buccal area is good. The buccal area is good. Then see, if I place another implant in the second premolar. Okay. If you see, I cannot place the anterior implant. Of course, canine implant is out of question. Even one implant you cannot place till the nasal floor. So what the alternative plan is, in this kind of situation, what I do is I will place a 1-1 implant now. Okay, first we will plan for the 1-1 now. Okay. Okay, this is 1-1 implant, right? Coming out to the nasal floor here. And I will place one more implant in the 1-2 region. Okay. See, here it looks deformed, don't worry about this. Okay. See, the bone width is little bit less, so I am changing it to 3.75. Okay, see, this is from preview. This is 1-1 implant exiting the nasal floor. This is 1-2 implant. Okay, 1-5 implant we will. One frame implant is almost in the nasomaxillary buttress area. Okay. Or what? Okay. Can you see? You can appreciate, no? The width available near the nasal floor is very less for us. In the occlusal plane, it looks very wider, but here, no. This is the anterior wall of the sinus, anterior extension of the second premolar area. This is canine. This is the middle of the incisive canal appears. So another plan is, what you can do is place one implant, tilted implant in the second premolar, good, nice, long implant, and 1-1 implant is also nice, good, long implant, and place one good pterygoid. Right? This is the pterygoid. Pterygoid also good bone. See the pterygoid now. So whenever you plan pterygoid or whenever you plan maxilla, better remove the mandibular segment, then only you can see what is happening. See, because of the anterior metal ceramic bridge, there is a lot of artifacts. This is the back side of pterygoid. you can see, no, this is the pterygoid region, this is the medial pterygoid plate, this is the lateral pterygoid plate, this is the area between these plates, this is our target area, this is the tuberosity. Okay, it enters from buccally, it enters medially and it comes here. Okay, one good long implant we can place 3.75, 20 also. So one implant here, one implant mesially tilted, one implant straight. This I already discussed once. V2 we are design. Okay, so this is pterygoid 1. Okay, this is this premolar, anterior to premolar one tilted like this. One central incisor, another central incisor, another tilted, another tilted. So this is like a, it will look like a V to V. Okay, no more implant is needed, provided they are good, long, in good bone, good diameter. This is more than enough. You don't have to be worried about anything. Or what you can do is place this implant tilted, place another premolar implant tilted, place one implant short. Do not go till the nasal floor, and give one tooth cantilever or whatever it is. In this scenario, this molar, no, this molar palatal socket looks good. Okay, so we are see the palatal root. See, the palatal root is good, palatal socket is good. You can place a wide BCS, 5.5 BCS or wide compressive, 5.5, no? 5.5 compressive, you can place 5.5 to 10, it will nicely. Even the post follow-up X-rays, no? Wherever we placed a wide diameter in palatal socket, they integrated nicely. Initially I was having some doubt, but now it works good. So if the socket wall is well and healthy, there is no peritonitis, there is no bone loss, go for a wide diameter compressive. Not 4.2. 4.2 won't get good stability here. 5.5 will be better, or 5.5 basal. 5.5 basal, 12 mm. Okay, 12 or 10 mm with basal design. So right side planning is one pterygoid, if possible one short implant here, one tilted in the second premolar, and one implant in the ear. You may be thinking, no, you can place one more implant here, but it is critical. Otherwise, what you can do, you can place one more implant at the lateral incisor, but short. Otherwise, it may hit the premolar implant. So this dynamic we have to understand. See, occlusally the width is very wide, but see here, in the nasal floor level, it is very less. If we don't understand this, we will be placing 6 implants, no, or 7 implants, or 8 implants, 10 implants, straight. But if you see the nasal floor area, all implants will be close to each other, and the bone in between those implants will be very less or no bone. If they get necrosed because of lack of blood supply, they may get infection, and there will be pus oozing from the implants. Okay, and that may be the reason for failure for many cases. Okay, long term. So don't always think we have to increase the number of implants. Even a basic 6 is enough. If you put this kind of design, this 6 is enough. Okay, other implants just supplementary implants. Now we will plan for the left side. Left side second premolar is a healed area, right? Okay, so here the bone height is good. Okay, so the height is about 14 mm. It's a good length. Okay, we will just try mesially tilt. Okay, whenever we are tilting, always keep in mind we are complicating the situation, and we should be very careful. It becomes a technique sensitive procedure. Whenever we are tilting, we may miss the landmarks easily, we may lose orientation. Okay, like from home to clinic there is one route. Suddenly if you take a different route, unknown, you may miss somewhere and you may lose somewhere. So here if you just tilt slightly, you are entering a nasal floor, good quality bone, good length bone, you can see here. See, no? Okay, this one implant is good, and another implant. Always plan for 2-1 first. Okay, planning becomes easy. So 2-1 is the heel area. Okay, already extracted. That is why the patient went for
Bridge.
yes, bridge. Now we will remove the bridge. It is complicating our. See, whenever you are planning anterior implant, just stay close to the canal. It is very simple. Surgically, you will be opening this and you will be seeing this incisive canal, and we will be drilling just lateral to the incisive canal. So planning in this 3D reformed view is much more easier. In panoramic image, we may lose orientation. Okay. See here you can see this second premolar implant. This is one. Okay. But if you see in this panoramic view, you may lose orientation. Okay, it shows very different. Okay. Now we placed one implant in 2-2 and one implant in 2-5 tilted. The other option is placing one implant in the lateral area. Okay, a short implant. Okay. See, it shows it is very close, but if you reduce the length, it is okay. That means the mesially tilted premolar implant is coming close to our lateral incisor. So better place only 2 implant. Okay. Otherwise, what you can do is you have to place the second premolar implant straight. Okay. Place straight.
Short.
It will become shorter. 4.2, 13, something like that. Now you can place one more implant in the even second premolar also. Just we will overextend this implant just to see where they are coming out. From this view is very important during planning. You can see now they are becoming close to each other. And the premolar implant, we are targeting the sinus floor now, not nasal floor. If you want to engage the nasal floor, we have to tilt more mesially and engage this nasal floor. We will try tilting the nasal floor now again. Of course it will show close, but for the sake of understanding Can you see there all the 3 implants are close to each other, which is not favorable. So don't try always to place more number of implants. Even if the implant number is very less, make sure they are surrounded with good bone, good engagement, good stability, getting good nasal floor engagement. Okay. So what we will do is, okay, so only 4 implants in the premolar to premolar area. So this implant becoming close to each other, is a big problem for this patient specifically, because this patient, the alveolar arch is very much wide and she has got little bit prognathic, maxilla. The tooth are little bit proclined. So there is a difference between the arch length in the occlusion plane in the alveolar level and in the basal level. So traditionally how doctor's plan is from seeing the panoramic view. So you will see 6 implant, 8 implants even in between premolar to premolar area. Placing additional more number of implants, they think it is good, but it is not always so. Placing implants around more number of implants close to each other with no bone in between the implants will lead to failure than placing less number of implants. So number of implants doesn't count always. Okay. Now we will plan for the left molar. We will see how it is. So this is the second molar area probably, right? This is the palatal socket, which is not very good, but you can place a 5.5. Okay, these are all supplementary implants, they are not main implants. Okay, and coincidentally if you see here, this is the periapical lesion surrounding the root apex. You can see the sinus floor has been elevated. Okay, and if you see in one point of time, you can see the breach has happened. That means the periapical infection has gone into the sinus, and you can see the chronic sinusitis here, sinus inflammation. If you see, have you seen the right side sinus? It is very healthy. But if you see the molar, left side sinus, it is not very much good. Some chronic inflammation signs are present. Now we will see the 7 area. So, sorry, 8 socket. Even 8 socket is okay. You can place a short implant if you want. 5.510. Sorry. Okay. And we will just see how the pterygoid is present. Pterygoid has not come in this X-ray fully, right? So this is a pterygoid and tilt. Pterygoid is not very much favorable because the sinus has expanded even in the pterygoid area. Okay. You can place, but the pterygoid is fully covered in this cavity. See, no? If you see here, this pterygoid has come fully. Oh, sorry. But here, this pterygoid, no, it's not come fully. Okay, now better. This is the left pterygoid. You can place a good pterygoid here. So these are all ideal cases for going with screw retained multi-unit single piece. They are very ideal. If you go for screw retained multi-unit, just 6 implant is enough. 2 pterygoids, 2 premolar angled implants, 2 central incisor implant. If you do the same scenario with single piece, the challenge will be the pterygoid implant angulation. Pterygoid implant angulation will be less than ideal. It will be buccal and mesially tilted, right? Of course, you can bend. The bone quality in the pterygoid is good. but you cannot achieve good parallelism with all the implants. Whenever pterygoid is present, process insertion is quite challenging. Okay. Or one more option in this scenario is, especially if you are going for cement retained single piece implant, what you can do is you can knock out this right pterygoid and you can be happy with this molar implant on the right side. It is very good. Okay, you avoid pterygoid, so the parallelism issues are solved. The left side, you are placing 2 molar implants in the 2 palatal socket and you are avoiding pterygoid. That will be a good plan for this patient. If you have screw retained, you don't have to place this in between small implant. There is no need. It will actually complicate the screw retained process. Okay, just 6 implant is more than enough. But if you are planning for cement retained, for this patient, I am telling, knock out the pterygoid. Don't put pterygoid. Put molar implant, palatal socket. They are good implants. The anterior implant also, they are good. The only challenge will be in extraction. We should not break the buccal plate. If you break the buccal plate, then everything goes into trouble. Okay. See, the arch is very wide in the alveolar level, but it is very narrow in the nasal floor level. Okay, so this one difference we have to consider in mind. If we plan by seeing the OPG, we may make mistakes. So we have to use this 3D reformatted image. We have to see how much implants are close to each other in the nasal floor level also is important. Because long-term failures, they come because the implants are too close in the nasal floor area. Bone loss happens and failure happens. So we have to drop this idea from the brain. More implant is always more good, not always like that. What is the distance between the implants? How much good healthy bone can survive in between the implant? Finally, the bone surrounding the implant only determines the success, not the implant. Okay, healthy bone surrounding the implant. Healthy bone means it should get blood. Then only it will be healthy. If the implants are close to each other, actually implants are interfering the blood supply within the bone. So we have to keep the number of implants minimum. But of course there are certain instances we have to increase the number of implants like osteoporosis and all. But without breaking the rule. What rule? A safe inter-implant distance. Doctors see only the inter-implant distance in the crystal level. But what about the nasal floor level? What is that? Of course, if you see this picture, see we have selected 4 mm implant. No? In this designing software, it shows not very much tapered, but the real implant will be very much tapered. So the inter-implant distance will be much safer when you do than it actually looks here. The implant tip will be less thick than this what this software shows. So all these factors we have to keep it in mind. So sometimes you have to place the anterior implants without getting nasal floor engagement, just to avoid touching the tilted implants. So even in conventional, this technique is followed. So one implant will be tilted from second premolar, one implant will be tilted from, one implant will be in the 1-1 region. The 1-2 implant will be short implant. It won't be long. If it is long, it may interfere with the tilted premolar implant. So these things you have to keep it in mind when planning.